So we have a generous amount of time for any questions that you might have.
Yeah, I would say, just echo on that. So we actually just opened up a new hospital on Sunday this week, and we went from a mixed ICU to a pure 20-bed neuro ICU. And as our program has evolved and the APP started covering nights, that was the biggest value that the nurses identified, is that the APPs will actually walk in and say, this is what if the patient was going to deteriorate, this is what would happen. This is what you should be looking for. Let's examine the patient together. And it really, nurses said that the APPs elevated their practice. And I look at it where the more time I invest in them, the easier they make my job, quite honestly, right? So I think there is a lot of mutual learning between nurses and advanced practice providers in the ICU. I think it's a great point.
But I do want to also say that I have run into the opposite, where some of the advanced practice providers I've worked with seem to have forgotten that they were nurses once at the bedside. And it is so important that we don't sit over there in our little area as advanced practice providers and talk about what an idiot that new nurse is, right? We need to make sure we remember what it was like to be a bedside nurse, what it was like to be a new nurse, and to be supportive, right? We're not the doctor, right? Yes, we can make decisions, we can order tests, we can recognize, complex clinical situations, but we are a nurse first. And I think it can be very successful, like at your organization, where your nurses feel like you're elevating their practice, if we remember to share what we know.
I think that's one of the things that we need to clarify about our role. Expectations of really who we are as advanced practice providers out there. It's still so, we're so new, which you guys alluded to, and we're still really trying to carve out our path.
Mm-hmm.
And there, we still have a lot of work to do to articulate who we are, the value that we bring. I mean, we all have a sense of it, but how to coordinate that and publish that out, and that be, an expectation in facilities, is the real challenge. It seems kind of behemoth at this point, but it's crucial for our success.
Yeah, I think a common challenge, especially at academic centers, is how as an APP do you not feel like just another resident, right? You end up in this state of like perpetual, you're just a worker bee, and how do you actually carve out the time for the other professional responsibilities, whether that's a national committee, that's something presenting at meetings like this. How as an APP are you really fulfilling your other professional obligations other than just the clinical care? I think it's a really good point.
I have a real issue with that, because I think what happens many times is we become our own worst enemies. I've seen a lot of people, new in the role, they're so excited, they take on all the little monkey skills that are out there, because that to them is exciting, that they can now do these monkey skills that they couldn't do before. They're writing everyone's H and P's, they're doing everyone's dispos, and then before they know
point, and it's something that I've struggled with for a while. Many of you might know or might not know, I'm not an APP yet. I'm in the middle of my schooling, and it's something that I've thought about so many times. If I continue on this acute care track, am I going to be a PGY 2 or 3 forever? And how do you inspire people who are already well seasoned in their field to keep going with education if all they're going to do is end up being a scut worker?
To Anne's point, just to continue down this path a little bit, I think it depends somewhat on your structure of advanced practice at your organization. How many people have like a center of advanced practice at your organization? Okay. Exactly. So, yeah, so at Stanford, even at Stanford, we have over 500 APPs within the health system, and we have a center for advanced practice, but not all report up through it. It's really interesting that you even have a structure, but it's not utilized within the health system fully. Within that structure, though, we actually have, we call it PEP time, professional engagement time, where you do an application to say, I'm on this writing committee, I need X amount of time, and then you're given that time. So it really is, that center has protected us because they looked at our turnover, and it's horrible at Stanford. Our turnover is higher than the national average, which is embarrassing to say, but they're trying to put all these things in place to say we understand APPs are not residents and they have other professional obligations, and how do we help carve that time out? If you don't have a structure like that, I would reach out to other organizations that do to see if you can build it. Because if you're reporting to a physician, you're not going to get the support that you need.
That's absolutely right, Liz. And I used to be a director of such a center when I was working under Carlin Kirk, but it was incredibly nurturing and protective because we made sure that every single advanced practice nurse had some form of scholarship that he or she were working on. And, the next thing you know, you've got publications coming out of your place, you've got podium presentations. It was great for the institution. The unfortunate thing is that a lot of administrators are kind of nearsighted, and they don't necessarily see that. They all want magnet, everyone wants that, but they don't want to dedicate the funding to support such a position.
Yeah.
And that's the first position to be cut when people are looking at the bottom line.
Well, and I think actually the first position, and this is something we've done to ourselves, we've fought so hard for title protection, so you've got your nurse practitioner, and then you have your clinical nurse specialist. The clinical nurse specialists are the first to go because they are not physician extenders. And when we talk about advanced practice providers being able to give what the bedside nurses need in terms of elevating their practice, I have actually seen it happen over and over again at multiple hospitals where that CNS becomes that resource to the nursing staff, and the NP is becoming that PGY 2 or 3. And so I think we've done it to ourselves by saying, okay, we're all going to specialize so much that I'm going to sit for this board and I'm going to sit for this board. I actually was fortunate enough to participate in a dual program when I became an advanced practice nurse, and it was CNS and NP. And they've subsequently done away with that dual track because they realized you can't do both. And so you've got to choose one or the other. So I think we've done a little bit of that to ourselves. Other?
To go back to the staffing, as far as the stroke units and neuro patients and like so I get the feeling that, based on observation, that this is probably a bigger problem than maybe we realize or we're admitting to. And I just want to know what your thoughts are on how we should address it.
Well, I will tell you from my personal experience as having the responsibility over inpatient units that are critical care and non-critical care, I think one of the things that we need to be doing is advocating at the corporate level. I think that, people find you become more and more remote from the bedside, and you're not providing direct patient care, but you have the knowledge to understand what it takes to provide this bedside care. So one of the talks, I think last year at SVIN, my talk was about really becoming a stroke nurse leader, because you can take your clinical expertise and background, and I think we need to have a voice at that table. And being able to advocate for what's appropriate, being able to back it up with data, showing the outcomes of the patients, I can tell you, we did a fabulous study in our ICU internally when we had an increase in coding. And we tied it directly to the fact that we had 18 beds that were always full and we only had one patient care tech on the unit. And so every time that patient care tech accompanied a patient to MRI, we had no tech on the unit. So now you've got a nurse, he's got 2 very critical patients, and some of those elements that revolve around hourly or every other hour responsibilities, think about things like oral care, things of chlorhexidine bathing, they sort of fall to the back seat when you've got 9 million drips and you're running around trying to keep this person alive. I'd rather have them dirty and alive than clean and dead, right? So I think we need to advocate at the highest level, but we have to have the information to back it up. So many of the clinical trials that Anne, you've been responsible for, conceptualizing, really talk about how we can demonstrate the value of our care and why we need to have this type of staffing. So I think that we need to be advocates and be very vocal about it.
If you do have the opportunity to design some kind of study like this in your institution or in a system, you definitely need the support of the finance people to bring to light what your return on investment is for increasing staffing or to staff smarter. So definitely have a financial portion of it that you can bring to administration, because that is what really speaks to administration. If you can prove that you are getting less readmissions, and it's not an easy thing to do. It is not an easy thing to design a study where you can actually prove financial gain to the institution or less of a loss. So that's,
Without question, if you look at the metrics that every hospital is looking at, they want to decrease length of stay, they want to decrease hospital acquired condition, they want to increase their patient satisfaction scores, and they want better productivity. So they want, essentially, fewer staff for more patients. So I think you need to speak to what those high level, and these are all, I've not been to a hospital that doesn't have all of those things on their goal profile for the organization. So if you can speak to those things and you can speak to them credibly, I think we're going to push the needle on this issue.
The only thing I would add, Wendy, would be it's not about pure patient ratios, right? We all know the patients are more complex. So it's not about you're on a stroke unit and it's 4-to-1 ratio. Those 4 patients could look very different, right? So it needs to be acuity based, and I think more organizations are moving towards that, but some organizations purely look at it as a number. In our stroke unit, we actually take post-TPA patients, even in the frequent neuro checks. If their stroke scale is less than 10 and they have no clear ICU need, they go to our stroke unit. Can you imagine if you had 4 post-TPA patients, if the staffing wasn't done acuity-based? So I think we need stronger models that actually...
It's very common. Yeah. I mean, our stroke unit takes TPAs too. What I think it really comes down to, because I go over and over this in my mind about, why does this happen in so many different places, that the nurses feel under-resourced, that they actually are, and that nobody is doing anything about it. Even the physicians are screaming about it, and still nothing changes. And to me,
charges.
You know,
Yeah.
I think now techs are at the ability where we can take on
Yeah.
more, and
Yeah.
I think maybe that would help some of the nursing backlog.
Well,
Pass
you know,
it off to some other professionals and kind of share the workload with the leadership.
but to your point, some of the best programs I've seen have techs very involved in the performance improvement initiatives in neurointerventional, right? So many things are time-driven, motion, it's almost like lean, like a lean process where you help to design a room, you help to eliminate wasted movement, really recognizing that there are tasks that can be done in tandem so that you're moving much more quickly. But I think that you are sort of the best person to lay eyes on all of this and to say what could make it better. And I think understanding how do you approach something, that's the elevation of the education provided that puts you in a position to have that voice. So I absolutely think, and you know, I have two of my very best neurointerventional nurses are in the back here, so I think that they could speak to how instrumental the techs are in our area, and that there's so much value. I've also been places that don't even have nursing in the neurointerventional suite. And really they say, well, the physician and the resident and anesthesia and the tech are managing everything. And you know what? I can't fault them with the exception of needing that clinical exam that we really would like to see. Everything I've seen is, you know, better documented, better captured, because you're focused on capturing the details. We as nurses are notorious for providing the care and never writing it down, right? And that's where we have the problems in neurointerventional. But I think there's so much value.
I am. I'm finishing up my master's degree, and that's kind of, my dissertation is going to be on Lean Six Sigma
Mhm.
and
So process, yep.
and staffing.
Yep.
And it's really funny if you look at the neurointerventional suite, you take everybody's role in the neurointerventional suite and put them into a swim lane diagram. It is very stark as
Yeah.
to where the workload falls.
Yeah.
You have everybody fill out
Yeah.
their own, like, hey, neuro nurse, what do you do during a stroke? And have them fill out their.
Stand in the
look at
corner
it,
and
they're like,
document
"There's
groin puncture time."
5,000 things in this lane, and like, well, I scrub, set my table, and then, when I'm done, I make sure I restock. And then there's like 5,000 other things, and it's like, I think we're missing an opportunity.
I did a couple of PI projects with the techs. We put them through yellow belt training, and then and had them spearhead the time, door to puncture. IR door to puncture. And they were so fast. They worked on this project so well that it became like a routine diagnostic was ready so fast that everybody was like, calm down. Like, we don't have to do it this fast for every single patient. And then the doctor was still at home when his patient was on the table ready to go. So, the passion that they had, and a lot of them took it upon themselves to actually get additional lean training, which was awesome because the hospital wouldn't pay for anything additional. But, the improvements that were made with a staff of 5 people was incredible.
I think identifying technologists in your workplace who are ambitious and have a passion for what we do is very important, because I see a lot of technologists getting burned out. They're not stubborn enough. We're told as technologists our job is to prep the equipment, stay out of the way in some places. Like, this is what you do, this is your lane, stay out of our lane. Nurses do leadership, nurses do research, nurses do process improvement, stay out of our lane. So it's very important, I think.
You're never gonna have a solid quality improvement or practice change unless you engage the entire team that is responsible for that project.
Yep.
Mhm.
So when you talk about this, I'm like, how could you not involve a technologist? If you're looking at a door to groin puncture time or any quality improvement project in the lab, a tech is essential to that. And I think, again, just like APPs, right, we have to define our role and our value. There's probably an opportunity for technologists also to better say, this is what value I bring to the team.
Mhm.
We don't do self-promotion enough or well enough.
Do you think there will ever be standards surrounding the ratios in IRC?
I think so.